Next speaker is Dr. Chandrashekar, whose introduction is not required, as everybody knows about him. So he'll be talking about deciphering the cause of for pain in musculoskeletal diseases.
I think yes. I think I'll just quickly go through in next 10 to 15 minutes how and what we have consolidated throughout this day. Basically, there are few issues I think we are all now wondering about. Should I treat or not when a patient walks into me with a pain? So we have always has a question that if I treat the pain, am I going to miss something? Which we do sometime when he has an abdominal pain or something which we are worried about. If I miss a sign, do I miss something or do I harm? But I think after listening to the 7 of the preceding lectures, we are clear. If there is a pain, it should be treated, and you should find some other way to figure out the signs and symptoms for which you are worried with. So we need to treat a patient who has a pain, and the question then comes is, how much should I treat? See, there are, I think, conflicting signals you got. Few speakers said that whatever you do, you may not overshoot a relief of more than 40 to 70% of the pain relief. You may not get an absolute pain relief in some situations. And if you look back and if you see a rheumatologist speaking about rheumatoid arthritis, we talk about a total pain free. If visual analog scale should come down to 0. I think when on one of my talk I said, showed very clearly, if VAS is reached 0, patient is in a good remission and less likely he is going to relapse. So again, how much to treat depends on what is the reason for pain and what any other cause for pain is existing and what else I can do. In any chronic pain, probably we don't look for a full clearance. When it comes to an acute pain or a pain with a cause like rheumatoid or any other inflammatory lesions, probably we can target to a total free pain intervals. Then we have questions like, should I use pharmacological intervention or should I use non-pharmacological intervention? Even in pharmacological intervention, should I use NSAIDs, should I use opioids, should I use any other dependable drugs which would cause more harm than the benefit? The major question that comes is, how much should I trade off? The risk to balance is the major question that we have. So we need first is to assess the severity of the pain. Probably the measures will help you, and assess the associated conditions. Does he has cardiac? Does he has gastrointestinal, renal, dependency, psychological factors and any others? Include all factors which are contributing for the pain. It's not just what you have seen. Look into every aspect of the patient as a person which would be causing the pain and how much discomfort the pain is causing to the pain. So all these factors should be put into one nutshell before you start weighing the risk to benefit ratio of your intervention. So point 1, intervention is required when there is a pain. Point 2, how much intervention we should give. Look into entire of the facts that are real in front of you, from the patient, from your examination, from every aspect of the pain to assess how much risk can I take with reference to relieving this pain. So as you know, the causes for pain could be multifaceted. It could be inflammation or it could be a low pain threshold. In a patient who has an inflammation, pain threshold lowers, or the patient may himself has a low pain threshold. In such patients, even the minimum inflammation could cause a lot of discomfort. And in our experience as a rheumatologist, we see with 3 joints swollen, patient complains a visual analog scale at 10, and with many joints swollen, patients still say, yeah, I'm okay, I'm able to manage my day-to-day course. So it's not that the inflammation alone will help. In addition, you have a low pain threshold which is going to influence the quantum of pain that is happening. Then you have a structural damage. It could be a structure or a damage in the joint or in the muscles which could be resulting in the pain. Again, it is influenced by the physically demanding occupation what he has. If it's a sitting job, probably he may not have so much of pain with his knee pains, or if it is a physically demanding job like an executive has to run around, the quantum of pain or impact he is going to have is much high with this structural damage. Then you have neuropathic changes or a neuropathic damage, again it is also influenced by the support, socio-economical factor, psychological factor, and in each of them, one patient may have all of them, all the other factors can influence. Here the hexagonal are the organic changes, the square are the extra organic, the outside the purview of what you can see within the physiology. So in a nutshell, a pain, either chronic or acute, has to be put with all these factors in your analysis before you start planning how you are going to handle the patients. So when any patient comes, we always are worried is, what should I target with this patient? Which if I target with reference to this patient, I get a maximum benefit out of it. For example, if it is inflammation, the treatment of choice is an anti-inflammatory drug. Probably in a patient with an inflammation, analgesics, even the morphine analgesics which doesn't have anti-inflammatory properties, may not be as effective as a non-steroidal anti-inflammatory drug. So suppose you get a situation where you cannot use non-steroidal anti-inflammatory drug because of the renal compromise, you need to add a small dose of 5 milligrams to 10 milligram of prednisolone, which works as an anti-inflammatory without much compromising on the renal function. Along with that, if you add a morphine analog which doesn't have much renal impact, can assist in getting over an inflammation caused pain. So this is how you need to work it out, analyze. If inflammation is causing the pain, your strategy should also tackle an anti-inflammation along with it. If it is a structural damage, more than analgesics, what you need is a support. Give a good splint, give a good knee braces, or replace the joint. That should solve if the pain is predominantly because of the structural damage. And if it is neuropathic pain, analgesics are not going to be the major drugs to be used. You need to go for neuroleptics or drugs which can help in the neuropathic pain. And of course, you need also have to take care of the socio-psychological factor. If there is depressed, you need to give an antidepressant along with it, and you need to take up all these issues when the patient's treatment of a pain has to be managed. So just to give a sample how exactly we work. This is a practical aspect what really happens. This is a patient who has walked in the first time with a polyarthritis of 3 years. He has both ESR and CRP elevated. His anti-CCP is positive. He has 8 tender and swollen joints. His visual analog scale is 9, and he is taking analgesics every day. He requires painkillers every day. So here it's very clear, the predominant trouble for him is inflammation, his tender swollen joints, and a need for NSAIDs. Elevated ESR CRP shows high. Introduce him with disease modifying anti-rheumatic drug as well as non-steroid anti-inflammatory drug. He does well. But what may happen is, down the lane after certain points, say after 5 to 6 months, you may see his pain is relieved only by 50%. CRP ESR has come back to normal. There is the swollen and tender joints is only 1. Visual analog scale still stands at 5. NSAIDs are not giving him much relief at this point of time. So probably here there are factors other than inflammation is generating the pain. So one, it could be a psychosocial factor, it could be a depression or a dependency or a demand for the work that he or she has at home, or it could be a fibromyalgia which may be overlapping at this point of time. So you need to take a call wherein you have to give him some of the drugs which we use in fibromyalgias or antidepressants which can help at this point of time. So when you start analyzing the patients, as I said, if it is inflammatory, anti-inflammatory, in this patient there is no structural damage, in this patient there is no neuropathic symptoms. So what we best have to see is there any problem with reference to the social or a psychological factor or a overlap of fibromyalgia. So what we did with this patient is we added pregabalin at a dose of 75 milligrams. In the subsequent 2 visits, pain were much more relieved. So when we are trying to handle a patient, we need a total detailed history. And we need to review and re-review at each visits. It's not necessary, we have branded this patient as rheumatoid arthritis, pumping NSAIDs, increasing NSAIDs or increasing DMARDs to whatever the maximum is going to help him. You need to review and re-review and ascertain the goal which you would like to achieve and be ready to revise your diagnosis. In a sense, even if it is a back step, you may think that, oh, I was pumping in NSAIDs, it's not anymore a rheumatoid which is active at this point, it's a fibromyalgia which is overlapping. Be ready to step back and review the treatment that you would like to, and that's going to help in achieving a pain-free scenario in the patient's conditions. So, I hope in this last 8 plus 1, 9 of the lectures, we are trying to figure out and understand how a patient who walks in with a pain needs to be approached, and there is multiple possibility of a patient who comes in with pain and the multiple possibility in the same patient when he continues to have the pain. So, these analysis in each step will help us in picking up the best interventions and achieving a good outcome from the patients. It could be a pharmacological, it could be non-pharmacological, it could be an alternative medicine, it could be simple meditation to counseling. Each of these are to be selectively chosen with a simple fundamental principle of the medical practice: no harm if you cannot help him. So, in a sense, we need to weigh the risk out of the benefit that's going to happen, and the time you feel that the risk is less than the benefit, you can pick up those interventions to help the patient to feel a pain-free life. In a sense, pain-free life is one of the fundamental rights of the human beings, and we need to try to achieve this. This requires a multidisciplinary approach, and that should help us to achieve this. Thank you very much.
Thank you, sir, for those wise words. Are there any questions? We'll end this session here. Thank you.
We would like to tell our speakers that the presentations made were very outstanding. Thank you all. Thank you very much for sharing your time and experience with us. As a token of appreciation for the time and valuable input you shared with us today, we would like to offer the small memento as an effort of appreciation. May I request Dr. Raghavendra to share the stage with us. May I request Dr. Vikram Jain to hand over the memento to Dr. Raghavendra. Can we have Dr. Raj Kannan on stage, please? May I request Dr. Chandrashekara to hand over the memento to Dr. Raj Kannan. Thank you, Doctor. Dr. Vikram Jain and Dr. Chandrashekara, chairpersons for today's third session, we are pleased to have you with us today, and we would like to thank you for your valuable contribution. May I request Dr. Sridharan to hand over the mementos to Dr. Vikram Raj and Dr. Chandrashekara. Thank you very much, sir.